Well, thank you so much. On Thursday afternoon, when probably many of us would like to be lying on a beach somewhere, as long as that beach isn't too hot, you have turned up to this workshop on strengthening partnerships between church-led initiatives and the health sector. So thank you so much for giving us your presence and your time this afternoon. I hope we're going to be in for a really stimulating 90 minutes. We've certainly got some fantastic guests. And what I want to encourage you to do, obviously, we're not going to go round the Zoom and ask for people to introduce themselves, because I think that would take too long. But we will encourage you to introduce yourself on the chat. So on the chat bar, would you send a message to everyone with your name, what you do, what your role is, in what kind of capacity are you on this webinar this afternoon, and just say something about where in the world you're sitting right now. You can be as detailed or undetailed as you want, but it's great just to get a sense of who's joining us from around the country. And while you're doing that, I'll give a bit of background for the conversation that we are in. As was said at the beginning, I work for the Churchworks Commission, along with some of the other people on this call, with my colleagues Jack and David and others. And the Churchworks Commission was something that came out of the COVID pandemic, where we saw the real benefit of church denominations, congregations and Christian organisations working together en masse to respond to a significant moment of crisis in our country, and to sort of come together and say, look, we can be more than the sum of our parts, and we can have a collective impact at a big time of need. And out of the pandemic, as we moved into what we called the recovery, those same churches, those mainline denominations, the big Christian charities in the country, and thousands of congregations agreed that really we should keep doing this. There was a real benefit to working together, to being united, to try and have a collective impact, and collaborating with government and finding ways in which we could make a contribution to particularly the most vulnerable in our communities by working together across denominations and congregations. And so that was the birth of Churchworks. We are chaired by Paul Butler, the Bishop of Durham. And we are privileged to have on our commission leaders from all of the mainline denominations in England, and then also those umbrella bodies, people like the Evangelical Alliance and Church Together in England. And the commission is very broad, everyone from the Anglicans and the Catholics to the Coptic Orthodox, all the way through to some of the newer churches, through the different kind of the Baptist, the Methodist, the Salvation Army. So really everyone is there. We figure there might be a few churches in the whole of the country that don't in some way come under the various names, denominations and groupings in the Churchworks Commission, but it really is precious few. And what's more, there are now, tens of Christian charities and thousands of local congregations working with Churchworks. One of the issues that our Churchworks commissioners said that we should look at as a church collectively during this period of recovery from the pandemic was the issue of mental health and well-being. And a few months ago now, we had a conference in Westminster Chapel in London, which was a fantastic day, stacked to the doors with church leaders from around the country, some of whom are doing the most amazing things, connecting with local healthcare providers and finding ways in which they can support their communities through the mental health and well-being crisis that we're living in, that we were already living in before the pandemic, but that has got significantly more challenging since the end of the pandemic. And so we heard from church leaders who are already doing stuff, and we had many other church leaders there who want to do stuff and were kind of working out where to start. And great speakers, Bishop Sarah, the Bishop of London, who was obviously once the chief nurse, people like Pastor Agu and Glyn Barrett, Olivia Marty, and then all kinds of different practitioners working at this interface of health and church, mental health, well-being, local church, community life and mission. And so one of the things we wanted to do was sort of take some of these conversations forward, because a huge amount of people expressed a greater interest in talking more on these issues and just hearing what's going on and contributing to the conversation about how local churches and national Christian charities and national denominations can make a difference at this critical time. So that's the sort of rationale for being here this afternoon. You will have to listen to me for precious little of this time. You will be very glad to hear. I will be sort of piloting us through, and we have some great guests. In a minute, we're going to be hearing from Dr. Ross Bryson. We're going to be listening to Faith Kenny and Pastor Mike Farley, and they're going to be talking to us about some of the things that are going on in churches, some of the work that they are doing locally to inspire us. We're then going to hear from Professor Bola Owolabi, who is fantastic. We worked with Professor Bola when she was a mere doctor in the midst of the pandemic, doing the most amazing job of helping people to get vaccinated and helping churches to support people and keep them safe and well. And so she is head of health inequalities at NHS England. And so she's going to be talking about how she sees the opportunity for churches to engage and interface with the health service and make a real difference. And then we've just got time for opportunity to share questions, to share ideas. And I hope that will be very useful for everyone here. And again, thanks for being with us. I think we should move to our first speaker. Obviously, if questions come up that you want to ask, feel free to chuck that into the chat at any time. Don't just wait until the end when we say any questions and then we have one of those kind of embarrassing silences and then have to round up. So feel free to put in any questions or thoughts that you'd like to share at any time. I will be jotting those down. But we're going to listen to three people who are pioneering this incredible work of helping churches to engage and particularly to partner with local healthcare providers and make a difference in the lives of their local community. And so we're going to listen to three people. We've got Dr. Ross Bryson, who's the Association of Chaplaincy and General Practice and Caris Medical Centre and Whole Care. I'm sure you will hear more from Dr. Ross exactly about that. But we're going to hear first of all from him about chaplaincy and general practice and how that all works out. Ross, are you there?
Yes, I am. Can you hear me?
Excellent. Ross, I'm Russ. Lovely to meet you. Thank you so much. And you're obviously coming to us from your surgery. So the whole setting looks fantastic and professional. And we're going to listen to you. We're really looking forward to what you're going to share with us today.
Thanks very much, Russell. Thanks for giving me this chance to spend a few minutes with you. Jack's got the slides loaded and I'm going to say next slide fairly frequently. So next slide, please. That's where I am at the moment, Caris Medical Centre. As you'll know, Caris is the Greek New Testament word for the grace of God. I've been a partner here for 35 years. We built this building 30 years ago. And all of this started because one local church had a radical vision for community transformation in this area from the 1980s onwards. Next slide. I've been involved in these organizations, all of which are charitable organizations that connect God's people with the health sector. I'll post all the websites in the chat, but you may get the slides afterwards if you want to. I really want to share a few principles that I hope are applicable to everyone and share a little bit of my experience. Next slide. So I guess this slide depicts the discussion today. How do we as church, people, a community called to fulfill God's purposes to his world, how do we connect with the health sector? Written above, you can read it in smaller print, is that term about values. I'd like you to think deeply about what values are. They're conceptions which people and organizations hold, which they believe to be good and desirable, and they influence the actions and the choices that we make. And as God's people, I think we should think more deeply about those values. And I find the term shalom or shalom values to be helpful. Next slide, please. Because I believe if we understand what God's values, kingdom values, shalom values, we can really meaningfully engage with the health sector. Next slide. This slide depicts shalom in a helpful way. Shalom is seen as the highest of all values. Those of you who know the Hebrew will know that shalom is a Hebrew word for peace, and Jesus is called the Prince of Shalom. And so where his kingdom comes, then shalom comes. And all these words written across the screen are from the Bible, and they describe aspects of God's characteristics, his values, the life of his people that we have the privilege to bring into the health service through our lives and work. Next slide, please. So that's what we should be doing. We can think more deeply about what we can contribute to the health service and to think a little bit more deeply about what the health service values are and what their needs are. Next slide. This is describing from the NHS Constitution that if we live, the health sector says, if we live by these values, we'll provide the best care for patients. And all those values, those 6 values, align completely with shalom. A word of warning that there will at times be a clash of values between shalom values and what we are bringing, because they're looking for Shalom values, but not necessarily for the Prince of Shalom. They may want Kingdom of God values, but not necessarily the King. So be prepared for a clash of values at time. But as we seek to move into the health sector with our values, if we can understand deeply their needs, then I think we can make progress. Next slide, because that's been what I've found over the last 25 years, and understanding the needs and seeing what we can contribute, we can make a difference. Next slide. This describes Caris Neighbour Scheme, which I set up 25 years ago because we realized there were so many unmet needs in our area. And so working with a group of local churches, we set up an organization that connects deeply with the health service and the needs in our area through the volunteering power of local churches. We have about 80 volunteers. We now have a budget of 300,000 per year, employed 10 staff, and we connect where other people are not connecting. And we've, particularly in the areas of loneliness, young families, asylum seekers, refugees, elderly. Interestingly, just after we started, the health service approached me because they wanted to connect deeply with hard to reach communities, and they know that churches connect with communities. And so in seeking to address health inequalities in the young children and families, I found myself leading for 6 years a government program called Sure Start to address those needs, because they knew that church could connect with communities. Next slide. Throughout our time, Caris Neighbour Scheme has been very aware that people need to be truly listened to. So we set up chaplaincy in general practice 25 years ago, and we've had that work in our team ever since. A place where people can be truly listened to, where faith, spirituality is on the agenda. People may be prayed for and offered that, but they really are given honoured and space time to be listened to by our chaplains. Caris Neighbour Schemes provided that by contract with NHS for the last 10 years. But that's just in this area. So next slide, we decided that this had to be made more widely known. So we set up the Association of Chaplaincy in General Practice. As I said, all these websites are available to you. That is a professional association which determines quality standards. It provides training, accreditation, and re-accreditation. And next slide. But we also need a provider organization that can do this across the nation. So in recent years, we set up this other organization that forms formal contracts with general practice that enables pastorally gifted people from churches to connect with the real needs of our communities through general practice chaplaincy for well-being. So do contact me if you would be interested in finding how we can help you connect your pastorally gifted people in your area with people in your community through your local general practice. Next slide, there's a quote from a lady who was helped by one of our workers. He was a pastoral worker in a local church, and he spent time on the phone after a formal referral. And if you can read the comment there, this is from the patient, the feedback, how much difference it has made in her life. She said, "It's been the light of my life. Thank you so much. You made me feel understood and normal. You've opened my eyes to spiritual things. I think God sent you to me. It has been a life changer." And the final slide is just to summarize what we've said already, that it's thinking deeply about our values, how we can bring shalom or kingdom values to the health sector by understanding what we can contribute, what the needs are in the health service. And I'll leave it there for questions later on. Thank you.
Ross, thank you so much for that. Can I ask you a question? And then we're going to say, that was a good point, because again, if people have particular questions for Ross or for Faith or for Mike or for Bola, just put them in the chat, and then at the end we will get them to the right person. I have a question just for now though, Ross. So give us a little sense of what does chaplaincy in a GP context look like? What would if we were coming to visit it and see it in action, what would we be looking at?
Thanks, great question. It's much more like counselling than it would be a chaplain wandering around the ward in a hospital having nice short conversations. So it's different to every other form of chaplaincy. And although we're part of the UK Board of Healthcare Chaplaincy, we are unusual in the sense that it's more like counselling. So it would be a 45-minute appointment in a room with someone who's trained in this field. And we initially explain what it's all about. We explain a connection with the health scheme, and we access to records and explain what we're here for, and then let the patient talk and explain what's important to them. And we facilitate the deep conversations that patients really value. They just don't have anywhere else to have those conversations. And if faith comes up, and if we can share scriptures, we can offer prayer, that's very much appreciated by patients. But it's very much in a confidential space where people feel valued and safe to be really open and honest.
Ross, that is so helpful. And at Churchworks, we have a particular interest in chaplaincy. I'm also an Anglican priest, and I find on Sunday I have so many conversations with people in my congregation who are struggling to find ways to live out their faith in the community. And one of the things we would love to see happen as a result of this Churchworks process and strategies for churches to be involved in mental health and well-being is to encourage people in churches, as you say, who are pastorally gifted, who get the right training, to go and be involved in chaplaincy as a great way of outworking their faith, but also serving their community. We will come back to that, I'm sure. Delighted to introduce you to Faith Kenny. I'm saying that hoping that Faith is here. Faith,
Hello.
are you
Yes,
there?
I am. Hello.
Brilliant. It's all going so well. Faith, lovely to meet you. You work in Southampton. I grew up in Portsmouth. There's a lot of
Oh.
rivalry between those cities, but we are an expression of Christian unity right now. And we're particularly interested to hear about social prescribing. That was one of the things in our conference a few months ago in Westminster that really caught people's imagination, was this possibility of churches getting involved in social prescribing. So please, tell us all about it, tell what you're doing, and inspire us as to what we might be able to do with social prescribing.
Great. Yes. So I'm part of a team of social prescribing link workers in Southampton, employed by Southampton Central Primary Care Network. And we have developed a sort of proactive outreach element of the service we offer, which we've developed in partnership with one of our local churches, St Mary's in Southampton. And St Mary's Church set up the meeting place, which comprises a pay what you can cafe and a social supermarket called the Marketplace. And it's a model that has been so successful, is now being replicated in other areas across Southampton as well. So the meeting place also, because it's in a church building, it's a great space to be able to utilize as widely as possible. So there are also classes and courses that are part of the offer. So there's recently been a seated exercise class for meeting place members and a digital skills course running alongside. And each week there's a member of the team that I'm part of, the social prescribers, and we're present in the space to provide signposting support to the community there. And the church's volunteers who sort of facilitate the space are brilliant at welcoming people, and then are able to point individuals in our direction if they need more specific social signposting type support. So it's been a really successful partnership we found that has drawn on the strengths and resources of both parties. So the areas of central Southampton that we cover are between the 10 and 20% most deprived neighbourhoods in the country, according to the 2019 indices of deprivation data. And individuals that we support often present with comorbidities and several barriers to accessing services. And with access to primary care becoming increasingly difficult for some due to demand, and then if someone has an additional barrier such as lack of IT literacy or language skills to navigate an online appointment booking system, it can be really challenging to access primary care. So we found that meeting people in the community removes some of this initial barrier to accessing support. So each week when we're there, we record the numbers and types of conversations that we have with people. And since the start of this year, we've had just over 100 signposting discussions with meeting place members, which kind of averages about 3 to 4 each time that we're there during the week. And so far, kind of the top 3 most frequent topics for discussion have been employment and benefits, which, given the cost of living sort of situation, is no surprise, mental health, and housing. So, but we have sort of discussed a whole wealth of other things besides. So physical health as well, family support for people with young children, and support for refugees and asylum seekers as well. So some examples of the recent kind of discussions we've had with meeting place members and the ways that we have then sort of supported them have included providing details for organisations that can assist with benefits assessments and offer debt advice. So we're always very clear that we're not trained debt advisors, but are able to link people with local organisations that can support directly with that. I recently signposted someone to a work club where they were able to get support to work on their CV and help to prepare for job interviews. I spoke recently with someone who was very new to the area and in fact new to the country, so wasn't really familiar with how the NHS worked. So actually was able to go through the basics of they've just registered with their GP surgery, how to submit an e-consult through the surgery's website, how to operate the NHS app, things like that. And another example is sort of having gone through a care needs assessment referral with someone online who had quite low literacy, so would have struggled to complete the referral form themselves. So I was able to kind of input while they spoke through things with me. So I think the work that we do at the meeting place is particularly helpful for those facing these multiple barriers to accessing services, such as not speaking English as a first language. And so, as I say, kind of in these examples I just shared, all of those kind of barriers were present there. So kind of low IT literacy, English second language, being unfamiliar with the local area and system. And so the meeting place has been set up to provide a holistic offer, which is very much all about kind of what social prescribing is here for. So it meets people's basic needs by the provision of food, and then in the winter months it provides a warm space as well for people to spend time in. It supports people's practical needs through the signposting support that me and my colleagues offer, and also offers spiritual wellbeing support. So volunteers from the church are available to talk and pray with people if that's what they'd like. So there's that additional pastoral element. And actually, we've just started a pilot with primary care chaplain Tim, who I see is on the call here as well. And he'll be offering a listening service in the meeting place for people that would like that sort of more in-depth input and just, to feel heard about what's going on for them. So we found that this kind of partnership offers kind of a way of meeting individuals where they're at, so in their community. And I'm all for social prescribing being situated in the community because I think it enables it to work at its best, for it to be preventative, essentially. So helping people to address these wellbeing difficulties before they reach a point of needing medical intervention because of the impact of social issues on their mental or physical health. That's what we found our partnership with St Mary's Church to provide for the local population. As I say, it's been a great journey to be on with the church. So thank you.
That's brilliant. Thank you so much for that. It sounds to me, I once upon a time I did used to run a GP surgery in a former life, and I remember very early on one of the GPs sitting down with me, because although I'm a doctor, I'm not one of those doctors. I'm not a doctor that's any particular use to anyone, and not on medical terms at least. And I remember one of the GPs sitting me down very early and saying, Russell, the thing you need to understand is that 80% of the things that my patients need are kind of completely out of my control as a general practitioner. And it really sounds like what you're doing with the meeting space at St Mary's is a way of trying to help address some of those issues that actually it's hard for a GP to really make someone kind of become less lonely or help them through the benefit system. Those kind of things are things that might create real health problems, but the solutions aren't necessarily something you can prescribe in
absolutely.
medicine. Is that right?
Yeah, definitely. And I think kind of like I say, sort of it being preventative, our kind of model of working at the church, because in theory we get to people before they reach the point of thinking, oh, I need help, I don't know where to go, I will go to the GP. So that is the idea, really.
That is brilliant. Well, please ping us some questions. It's great to see Tim Peppiatt on the call. He's a trailblazer in this field, and I will be putting him on the spot at some point in the next half hour. So we're definitely to hear from him in the questions and the discussion. But thank you, Faith, for sharing on that. On social prescribing, we're going to come to Mike now, Mike Farley, who's the pastor at the Bridge Church in Lincoln. Mike, are you there?
I am. Thank you, Russell. Nice to meet you.
Nice to see you. How are you doing? How's Lincoln today?
Lincoln, a bit damp, but still really good. Really
excellent. Good. Well, a big welcome, Mike. And tell us what's going on in Lincoln. What is going down, and what are you guys seeing locally?
Well, we're seeing a tremendous amount of growth in terms of partnership with the NHS, and I suppose the story started about 4 years ago. Really, I was. As you've got their community pastor, still am that as well, but my role actually now is as a community connector with the Mental Health Transformation Programme, which is an alliance with the NHS Lincolnshire. And it's kind of developed in those 4 years. And I was so pleased to hear Ross talk about Shalom, because that was really exactly where we sat 4 years ago. We were a church that was well known for its community aid projects and its community work, running a charity shop, running a public library, running food bank, various aid programs, whether it's food voucher projects during the summer holiday for families, or whether it's Christmas sack projects, bringing in Christmas presents for very vulnerable families. We were known for all of those across the city, as are other churches as well. We've had a really good relationship and network. Pastor Sian Wade would have loved to have been here today, but she's actually on sabbatical, which is another key part of what we believe is really essential for any of our workers within the church as well, in terms of our own mental health. And so she was and is running part of Transform Lincoln, which was the Active Faith Network, which is now part of the Gather movement across the country as well. And within that setting, there were a number of us who were talking about mental health, and we were getting connected with the local members of the NHS, particularly the neighbourhood team. I want to big up the neighbourhood teams; they're absolutely brilliant. And we were having conversations, and really what transpired was they came to us and said, just like Ross had just said there, we do community well, and it's lovely to hear Faith's story. It sounds like a very similar setup what's going on here. We absolutely love our social prescribers in Lincoln. And they came to us and said, you do community really well, we do the medical side really well. What if we could come together? Is there any way? And I suppose, again, that was that sense of sharing those values and understanding, like Ross has said, where some of those values will clash because the NHS respects faith, but doesn't necessarily, certainly organisationally, wouldn't say we're a faith organisation. And so that challenge is there, but also where do we align? Where do we come together? Where do those values meet so that we can work together? And soon we were able to strike up a really positive conversation. And so we had a number of those positive conversations. One was about the amount of people who go into crisis with their mental health during the evenings. Certainly Lincoln, our crisis team was very small. Transformation program was not happening in Lincolnshire at that point. It was just starting to be spoken about. And we felt that was a challenge to us as the churches. And there was a small group of us who got together and said, actually, I think we can do this. And there was the dream of one of the ladies, Stacey Marriott, who is a member of Acts Trust, a member of our church now as well. And she really dreamed about having crisis cafes. And so we said, rather boldly, maybe, but Sian certainly said that. She's like that. She's an absolute pioneer. She said, I believe the church can do that. And then said, church, can we do that? And we said yes, which was good. So cutting a long story short, just as the pandemic hit, we were ready to launch the cafes. And then, of course, lockdown happened. And it was a phone service for 2 years. A phone service was set up, and it became so well used that it was quite clear that the physical presence was going to be needed. But we needed those physical presences. So there were the assets across Lincoln. Where are the church buildings? Where are the church, perhaps cafes that are already running? Or are there churches that want to set up a cafe? And we were one of those as well. We said we would take on a crisis cafe. In fact, we took on 2. We've got 3 sites in the city. And we took on 2 of those to begin with. We've now gone down to 1 to allow other church buildings to be used. And so we got here at Bridge Central a whole cafe space. I really ought to have sat in there to show you what it looks like. Maybe when we go to questions, I'll wander through there so we can see in the background what our cafe looks like. Very similar setup to what I'm hearing of St Mary's there in terms of a meeting room. It's a cafe space. It offers free food. It offers these activities during the daytime as well as in the evening. And of course, this was from those nightlight cafes that we felt that a daytime one would need to take place. So we set up nightlight cafes in Lincoln. We set them up and as came out of the pandemic, became physical spaces. We were able to open cafes every single night of the week across Lincoln with training support from our NHS friends who are able to bring in that level of training support that our volunteers need. So whether it's mental health first aid, or whether it's suicide prevention, all those different levels of training that actually as a church, we really need to know. We really need to up our game as churches understanding mental health. We partnered early doors with Kinsuki Hope, and that was able to galvanize us as well in terms of our understanding, so that we didn't cause harm when we were trying to do good. And I think there's a real danger that sometimes we do more harm than good if we aren't trained up. And I think that's a really crucial thing. So all of us who are involved in this are getting our training up and getting our understanding up as well, from whatever background we're in. But we're able to set up those cafes every single evening. It's now gone, because of their connections with the NHS, it's gone county-wide. And so there are cafes in villages, there are cafes in towns run by multiple organisations. And I wanted to look there, I can't remember exactly, but we're well over 20 cafes all across the county now, maybe even more than that. And they're opening up more or less every single week. In fact, there were areas, I went to a conference in Grantham just a year and a bit ago, where we're representatives of primary care networks all across the county. And every single table was saying, we want a nightlight cafe, we want a nightlight cafe, because they understood. We've got the data that actually saying now, crisis levels in the city are going through the floor, and part of that is to do with that provision that the church is able to give in the night time. But equally, what we wanted to do was give that during the daytime. And so what we've done is open up our cafe during the daytime as well. And so now we have, from one person coming in about 2 years ago, when we opened it just after the pandemic, we've got 650 visits a month. We had multiple activities. I'll just list some of the ones from August. We're doing board games, summer crafts, Zentangle art, origami. We've got an emotional freedom group. We've got stretch and soothe activities as well. We've got multiple activities, low-level activities that take place. Our social prescribers prescribe into us as well. They're joining us during the week. We have the neighbourhood team joining with us. We're also really fortunate here that in the county, we're the only ones who've got our locality mental health team. That's the NHS team, actually have an office at our building. And we decided that we wanted to do this because our values were aligning, and we wanted to say where our values meet, where we can touch humanity and bring that level of wholeness to someone, and not just their emotional wholeness, not their financial wholeness, not even just their, even, I hate to say just their spiritual wholeness, but the completeness of their humanity can be touched. We likewise are in an area of really deep deprivation. Again, similar sort of a perspective from the indices of multiple deprivation that Faith was talking about. And my role as a community connector is to be that strategic role within my patch of the city. I cover 2 primary care networks. We have 4 connectors now employed by the church, and we're looking to actually see if we've put in a bid to actually host the lead connector for the county as well, all in alliance with the NHS, with the mental health team, that started as a conversation in 4 parts of the county, at least 2 of which were in churches, ours being one of them. And we said, what if this could happen? And if this could happen, what could it look like? And we said, this is our offer, the community side of it, and all the other offers came in. And now we have quite a transformation taking place that is generational in its perspective. And I really look forward to, like Ross has said, after that many years of establishing the work, maybe in 10, 15 years time, what might it look like in Lincolnshire? I think it could be profound. Yeah, just to finish off, I've now got funding through my role within the NHS to be able to establish wellbeing hubs like this one in the city, satellite hubs and outreach work as well. So I have the privilege of going to places and saying, I have money and there aren't really many strings attached to it. Are you ready to work with us within the community setting? And you don't have to do much more than you're doing. You don't have to do anything more. If you're running coffee mornings, that's brilliant. If you're running a warm space, that's fantastic. If you're doing a craft activity, there's a running joke in the county within the NHS that the knit and natters are back. And it's absolutely brilliant because that is exactly what it is. I had the privilege of going to a village called Ruskington where that was taking place. And a lady came in to this warm space. I'll just leave this to finish. She said, I'm trying you out. I'm just checking you out. And she stayed for an hour and a half. She was knitting and nattering and she felt totally connected, and she'd been isolated for over 2 years. And I think that's a profound difference that we can make as a church.
That's fantastic. Thank you so much, Mike. We can have some questions to you. I know where I was the first time I heard about the work you were doing, Mike. We've never met before, but we had a Church Works Commission with government ministers speaking to a number of our national church leaders in the Westminster Central Hall in Westminster, and we had a comfort break, and I was in the gents' toilet, and without too much detail, Andy Frost came and grabbed me and said, "You need to hear about what's going on in Lincoln," Andy from the Gather movement, and so it's great to hear the story again in more salubrious context, but also interesting you mentioned that funding piece at the end, because I was having coffee with Andy. Andy actually just lives down the road from me here in Southwest London. I had coffee with him the other week, and he was telling me the growing number of churches that are getting resource and funding from the NHS precisely to be able to do this amazing work. Well, thank you so much. Mike, we'll come back to you with some questions later. It's my absolute pleasure to introduce Professor Bolla. Professor Bolla, are you there? I'm hoping so. There's a PowerPoint. Professor Bolla, are you with us?
I am here. Thank you so much for inviting me. And Bola is absolutely fine. Thank you so much for inviting me.
And Bola, thank you so much. The first time we met, we were in a room with senior leaders of the black churches in the United Kingdom, and I think Nadeem Zahawi, it was obviously a Zoom room, and we were discussing the challenge of how we help people who might be fearful of the vaccine to get vaccinated. And it was astonishing to me to see what the church did, the role that churches played in helping people get vaccinated. And then you and I did an event where you were very clear that those churches had helped to save very many lives. And so I think one of the good things coming out of that horrendous period is that we did recognize that the work of healthcare from health professionals and the work of community care from churches and other places of worship aren't in tension with one another, but they can come together and work together and complement each other well. So we're really glad to have you here. I hope those presentations inspired you as they did me. We're really looking forward to hearing what you've got to say to us about how we might be able to work church, health service together more closely in the future.
Thank you so much, Russell, for the invitation and also taking me back to what was a very challenging time, but in many ways, we learned so much, as you've just said, in terms of the role of the church in making such a material difference in the lives of the community. And thank you to everyone who has spoken, because what you've done is you've encouraged me that beyond the pandemic, the church has continued to be present in this space of making a wider difference in the lives of our communities. And that's an enormous encouragement, actually, because when I was getting ready to talk to you today, I was thinking about the vaccine program and reflecting on how that really has given us a blueprint and a template of how the church can powerfully affect the lives of people for good, working with the healthcare system. If I may go on to my next slide, please. Thank you. So this slide is really just to ground us in why this conversation matters going forward. Is we know that health inequalities aren't new, but the thing that the pandemic did was to worsen them, was to force them into all of our consciousness, perhaps in a way that sadly maybe only a pandemic could have done. I mean, many reports have been published about health inequalities for absolutely decades. But what happened in the pandemic was, as the data started coming through and we realized that, if you came from the bottom 20% of the population that we call the core 20, then, your likelihood of dying was double the likelihood of somebody who came from the most affluent 20% if you got the virus. We saw that people with learning disability and other disabilities, 6 in 100 people who died had one type of disability or the other. We saw that people from ethnic minority communities bore a significant brunt of the death toll, compared with others. And one of the things that I started to say, because initially people were saying the pandemic is the ultimate leveler, but as the data came through, I had to say, no, it's not a leveler, because whilst we were all weathering the same storm, we didn't weather the storm the same. You know, many people in our communities didn't have any boats at all. Some had leaky boats. Others had the privilege of cruise liners. You know, if you were living in a 5-bedroom house with a dedicated study and you could work from home, it wasn't the same as living on the 15th floor of a high rise in 1-bedroom flat with 6 other people. So we weathered the same storm, but we absolutely did not weather it the same. And therefore, I think that is where this human cost of the pandemic, and I just wanted to ground the conversation in that as we go forward. Just on to the next slide then, please. Thank you. And this next slide is to then start to think about, okay, so what is it that the church can do to help? And I really liked what Ross said. The slides are not moving, by the way. What Ross said in his opening remarks about values. And it's so important, I think, that we hold on to what Ross said, that as the church seeks to work with the NHS, I'd like to say that the thing that made the voice of the church so powerful during the pandemic is the concept of trust. The community trust the church, and they trust the church because they are clear about its values. And I said that, you know, one of the things that a colleague of mine, Professor Kevin Fenton, began to say is that the pandemic also showed us that trust itself is a social determinant of health. And therefore, as we move forward from here, I think it's absolutely crucial that we hold fast to what Ross said, that the church needs to be clear about its values and be consistent to those values and hold on to those values, because that is the basis of the trust that the community reposes in the church. And it is that trust that gives the church the ability to make the difference that it does. And I couldn't emphasize that enough. And so if we go on the basis of that, what are the dimensions of action? And you'll see that I've put advocacy as a really important dimension of action. And I'm going to read from Proverbs 31, 8 and 9 to underpin what I'm saying about advocacy, where it says, open your mouth for the speechless in the cause of all who are appointed to die. Open your mouth, judge righteously, and plead the cause of the poor and needy. I think if the church ever needed the basis for its dimension of action in advocacy, I hope that that scripture reference gives the anchor. The second thing is, as an anchor institution, and many of the examples that have been given around the crisis cafes and so on, I think they are practical applications of the church as an anchor in the community. And I'll talk a little bit more about what I mean by that anchor element. I think there is something about alignment, and I mean alignment of values and alignment of priorities. And I will talk through that in a little bit more detail. I also would like to invite the support of the church as we take forward the Core 20+5 approach as a mechanism for reducing healthcare inequalities. And finally, connection. Shan Lockwood of Community Catalyst said something to me coming up to 3 years ago that I've never forgotten. She said, purpose and connection is what enables people to live their best lives. And I think that the role that the church can play in connecting people with purpose, in connecting people with other humans, and in connecting people with the real essence of being. I think it's really important to ponder what the role of the church in connection means across those dimensions of connection. And just on to the next slide then, please. Thank you. So talking about alignment in terms of priorities, I just wanted to put here for your attention that when we go into the various conversations, it's worth being aware of the health inequalities legal duties on the NHS. And it can be found in the 2022 Health and Care Act. And I think maybe someone being familiar with these duties, not everybody needs to know the chapter and verse, but I think someone understanding them would be helpful, because it means when we get into conversation with the NHS, at least we're coming from a position of being informed. There's also the NHS long-term plan and the commitments it made in relation to reducing health inequalities. Every year, the annual NHS England priorities and planning guidance is published. And in many ways, it directs the work that the NHS does. And I think it's worth being familiar with what it says, particularly in relation to reducing health inequalities. And finally, again, every year, the government publishes its mandate to the NHS. Again, I think it's worth taking the time to read and understand that when it's published, not necessarily the chapter and verse of it, but at the very least, the health inequalities elements of that. And just on to the next slide then, thank you. And I just again want to go back to what I was saying around anchors. So we know that health inequalities are not just about people's ability to access healthcare. Health inequalities are driven for the most part by the wider determinants of health: education, employment, housing, household income. These wider determinants are the biggest drivers of health inequalities. And I'm deliberately starting with them because they do contribute to roughly 80% of the health inequalities that we're trying to address. And you'll see why I started with the wider determinants, or the social determinants as we sometimes call them. And then just on to my next slide, please. Thank you. So this slide here is then about healthcare inequalities. So we've designed the Core 20+5 approach as a way of making the complex issue of healthcare inequalities a little bit more accessible, a little bit easier to grapple with, and bring us into that action space. So what is Core 20+5? Essentially, it is the approach that each of the 42 integrated care systems across the country have been asked to use to tackle healthcare inequalities. The Core 20 are the 20% most socioeconomically deprived populations. So we are asking each ICS to be clear, who are your Core 20? We're also then saying to them, don't forget your plus. The plus are the communities that may not even show up in the data. Homeless people, people who are rough sleeping, Gypsy Roma traveler communities, people in the criminal justice system, people in the asylum seeker and refugee system, ethnic minority communities, and others. They are the plus. So we're asking HICS to know who your Core 20 plus are, and then work hard to improve their lot in relation to maternity. And we know, for example, that Black women are 4 times more likely to die in pregnancy or the year following delivery compared to their white counterparts. Serious mental illness. We know that people living with serious mental illness, regardless of ethnicity, race, or any other consideration, their life expectancy is up to 20 years shorter than everybody else. Respiratory disease. We know that people living with asthma and COPD, chronic obstructive pulmonary disease, again, significantly shorter life expectancy. Cancer, early cancer diagnosis. What is the role of the church in encouraging people? Go and have your breast screening. Go and have your cervical cancer screening. When that fit test comes in the post for colorectal screening, please do it. Don't put it in the bin. Hypertension. You know, for example, the work that the Beacon Trust, I think I saw somebody introduce themselves as being from the Ascension Trust in London. They have 6 sites where they're checking people's blood pressure. Hypertension has no symptoms. People only know they have a high blood pressure when they keel over with a stroke or a heart attack. So what is the role of the church in opening up the space, for example, for people to have their blood pressure checked in church? You know, for example, and signposting then onto the GP service. You know, you talked earlier on about Pastor Agu. When we were able to put the vaccines in the church, it made it easier for people to access. Smoking. We know that smoking contributes significantly to health inequalities because of people dying so much earlier than they need to, because smoking contributes across these 5 conditions. So that's the adult version. Onto the children and young people one on my next slide. Thank you. So again, children and young people, same again, the core 20 plus population as the biggest sufferers of health inequalities. But look at the conditions that we're looking at in terms of children. Asthma. When you look at our comparisons with our OECD community, we have the unenviable position of large asthma deaths. Look at diabetes in children and young people, epilepsy, oral health. You know, what can the church do in terms of oral health promotion? Notice I didn't say dentistry. You know, how can we amplify oral health? Just simple, basic, working with our public health colleagues, advice and guidance, especially to our poorest households. What can we do in the oral health space before we even start talking about access to dentistry? And finally, again, mental health in relation to children and young people. This is what Core 20 plus 5 is. And my ask today is, what can the church do to help us across these clinical areas to reach these Core 20 plus communities? They're not hard to reach. They're easy to ignore. They're seldom heard. And if I just go on then to my next slide. Thank you. And here I just want to introduce you to, we've tried to develop what I call a delivery ecosystem, but I draw your attention particularly to the Core 20 plus connectors. And I'm asking, what can the church do to become Core 20 plus connectors? You know, the Core 20 plus connectors, they are people from the community, of the community, the trusted voices that can get the messages about these clinical areas over the line in a way that even as a GP, I can't. And so it's the Core 20 plus connector role and how it can help us in terms of messaging around smoking cessation, messaging around please come forward for your early cancer checks, please come forward for your blood pressure checks, etc. And on to the next slide then, please. Thank you. And having said all of that, I want to talk about the role of the church as an anchor in place, an anchor and a partner in place. What are anchor institutions? They are large, but I would say not necessarily large, public sector organizations that are unlikely to relocate and have a specific and significant stake in a particular geographical area. They are anchored in the surrounding community. And I want us to consider, what is the role of the church as an anchor institution in the places where we are? For example, giving young people access to volunteering opportunities, work placement opportunities. Let me go on to my next slides to give some examples of practically what some places are doing. For example, the organization called Feeding Families. They've partnered with 10 NHS trusts to make sure that when people are discharged from hospital, they're not going to a cold home. They're not going back to a home where the milk that was there when they were admitted is still the milk that is in the fridge. And so they're providing these welcome home boxes so that when somebody is discharged from hospital, there is something very practical that makes that transition from hospital back home to be as comfortable as it can be by addressing the most basic thing in terms of food and toiletries. Now they're working with 10 NHS trusts across the northeast of England. If I go on to my next slide to another example. Thank you. And this one here is around what we describe as inclusion health. So people experiencing homelessness and rough sleeping. And this is a project working with GP surgeries in London, in the Tower Hamlet area, working with my colleague, Dr. Victoria Tozu Brown, and just making, the connections and the links between people who find themselves in these circumstances with their GP surgery, playing that translation role for those who find themselves at the margins and the peripheries of society. On to the next slide then, please. Thank you. So this next one, compassionate communities. Again, it's about, working, for example, with the Imperial College hospitals around food and fuel poverty. Poor mental health. How might the church help to bridge the gap between hospital trusts, primary care networks, and the communities in which we are anchored? People for whom there's digital poverty. For example, I often say having a telephone or a video consultation with me as a GP in a plush accommodation is not the same as having a video consultation with 6 people hanging over your shoulder. What might the church do in providing digital cafes where somebody can come in the comfort and the privacy of the church premises and have their consultation with their GP or their hospital consultant and feel able to be their true selves rather than talking in couched language, because there are all these other people in this tiny flat and they're trying to have a personal consultation. That's another example, as the cost of living crisis is going forward. Again, we know there are people who are struggling with transportation costs to come to their hospital appointments, so therefore they don't turn up, to important things like cancer appointments, children who were not brought. When you look at what we call was not brought children, and you look at it and we ask the question, why aren't you bringing them? Can't afford the transport, 0-hour contract, caring responsibility. They're not rocket science things, but they're actually the reassuring thing, the refreshing thing is they are by and large things that we can easily fix once we think about it. So these are the examples. Another one, if I go on to the next slide, thank you. Is bear with me. So again, thinking about anchor institution, we know that some of the community organizations in Mid and South Essex are working with the NHS Trust to support people with learning disability, for example, to access apprenticeships, to access work placements. They've got a digital hub in the center of town. I spent the day with them, where it's a community hub. They're equipping people with digital literacy skills. How might we, train people up to become digital eagles? Whatever name we give them, digital buddies. Can we train people to help? So that when you engage with the NHS app, increasingly a lot of our services are going to be accessed through the NHS app. And I'm saying we need to mitigate against digital exclusion. So what can the church do to mobilize this network of digital bodies that can come alongside people and equip them and enable them? What can the church do in partnering with private sector organizations? I know, for example, Vodafone, they are repurposing old mobile phones, making it available to people experiencing homelessness and rough sleeping. Some of these innovative things that we can do so that we address the digital poverty in terms terms of devices, digital poverty in terms of data, digital poverty in terms of connectivity, digital poverty in terms of the built environment. These are the 4 dimensions of digital poverty that we can consider what the church might be able to do. I'm going to round up because I know we need to get into the conversation, but just on to my next slide, please. Thank you. And so here again, if you look at Leeds Teaching Hospitals, they're doing some work whereby when people put in a tender for any service, there is a social value badge that you need to fill out. How is your tender going to support the most disadvantaged people in this community? Are you going to give them jobs? Are you going to employ them as part of this building process that you're putting together? You know, are you going to give them apprenticeships, for example? You know, just these are examples about how can we use our estate. So many community hubs have been closed, especially for children and young people. Many of us have very large church facilities. How might those facilities become community hubs for these children and young people and get them off the streets into places of sanctuary? You know, I know, for example, Dr. Laura Nielsen in the Hope Citadel, you know, the fantastic work that they're doing there, the examples that Mike has given, the examples that Ross has given. How can we begin to use our estates as places of hope and sanctuary, children and young people, and getting them off the streets and equipping them with, you know, digital skills and life skills and so on, so that they come back into the world, they're equipped, they're safe, they feel empowered, they've been connected, they have a sense of purpose, they have a sense of dignity because they've been connected with purpose and they've been connected with others. Just onto the next slide, please. Thank you. But I just want to talk about the importance of being strategic and intentional about all of this. And I think each church needs to think about what is a priority issue in your place, and what are the communities that we're wanting to particularly focus on, and how are we going to talk to those communities to make sure that the solutions we develop are authentic because we've co-produced them with the communities that we're trying to help. I ask again, how might you support us with these core 20+5 ambitions that we've talked about? How can we use it to catalyze action, not just by the NHS, but by the church as a partner? And how are we going to track our impact? How are we going to make sure that we're not doing a whole load of activities, but without being able to demonstrate the impact? But I will add to this, that impact is not necessarily the number of, don't get too hung up, especially as the church, in terms of impact, because I know for a fact that sometimes the distance between what you say to people at the end of the church service, many of you have talked about people who walk up to you at the end of the service. There is sometimes a gap between that wonderful conversation you have with somebody and a change in their lives. And the fact that there is a time interval doesn't diminish the power of that conversation, is just what I want to say. So let's not get too hung up about, because I had a conversation today, we need to be able to measure the impact next week and so on. And I think this is probably my final slide, because I'm keen to hand back to Russell so that we can get into the conversation. And I will leave you with this thought: we can have action at all levels, whether that is nationally where I sit, at the level of the regions, at the level of the primary care networks, in place where many churches are, is to just say that action at every level is legitimate. And my parting shot would be, and in the midst of all of this, I go back to what Ross said at the beginning. Let us be clear about the values and the mission of the church, and keep that at the center as the partnerships evolve. Thank you.
Well, I thank you so much. That was, I mean, I've run out of paper, I think, from my notes. But there was so much there that was kind of captivating me. a couple of quotes. That one about trust itself is a social determinant of health was really, I mean, a number of you messaged me on that. I'm thinking we're going to come to that in the questions. But then that idea that purpose and connection help people to live their best lives. And yeah, just so much there. In fact, Daniel Singleton sent me a message saying that he was losing connection because he's in the middle of the Irish Sea. So I think he wins the competition for the most kind of creative venue for attending our webinar. And so was asking, is this going to be online? And I'm sure it will be made available online at the Churchworks website. And part of the reason of today is to bring people together who are already doing these things, to think about how we can amplify this message to the wider church, which we will come to in a minute. I think that's what we're going to make our questions about. Helpfully, quite a lot of the questions that are coming into me are all about how do we get this message out wider. We don't want to be just kind of preaching to the choir here. We want to be helping churches across the country to take on board the opportunities that are theirs right now to get involved in this as a mode of mission and ministry and at a time of real opportunity, but also a time of real challenge. Dr. Bola, we've had a couple of questions for you, Bola, which I'm going to come to. B-Joy, you've got a question. I'll let you ask it out loud because then we get to hear someone else's voice other than mine, which is always a good thing.
Brilliant. No, thank you, Russ, and thank you, Professor Bola. It's really great to hear from you, and thank you for sharing that really insightful presentation and information of how we can be better equipped at serving our communities as the church. I suppose that's kind of the basis of my question. What are some of the issues and what are some of the challenges of trust that we as a church need to know that have been barriers for some of these communities in accessing healthcare?
Thank you. And can I first of all say thank you, B-Joy, for the work that the Ascension Trust is doing. You are making a difference, whether it's in terms of the blood pressure checks that I talked about earlier on, but actually more recently, your work in terms of fruit and vegetables on prescription. Yet another example of very practical, tangible things that, the church can do. I think the answer to your question is where I started, prompted by Rose's opening remarks, that, for me, trust is a function of fidelity and consistency of values. People intuitively understand what the values of the church are, even people who may be unchurched, and they understand where there is deviation from those values. And it is the deviation from those values that materially erode trust. It's actually not that complex. The community and the society understand that the values of the church mean that it's often countercultural. People understand that. They lose trust when there is an attempt to somehow diminish that, because people see that for what it is, and that is what erodes trust. People actually are more likely to trust when they see fidelity to values, even in the face of significant challenge. That, for me, is my personal reflection.
Well, that's very helpful. I'm going to come to Gillian Strain in a moment from Go Health, because she has another question for you related to trust. And from there, I'd really like us to think about, well, actually, how can we take some of the content? It's been very rich, this conversation so far, and listening to our various speakers and what's going on and the sheer opportunity that's out there. So then I'd really like to move us into a conversation about how can we maximize the amount of churches around the country who are embracing the opportunity as well as the challenge and making a difference. And I know we've got some people who've got some thoughts on that, but Gillian, you're there somewhere. Please ask your question. That would be great.
Thank you, Russell, and thank you so much, Bola. My question, I feel you've answered it a little bit. So I was raising the question around trust and the church as an institution. There's a lot of erosion of trust for many reasons, particularly safeguarding, right? And institutions generally are less trusted than they were. But I feel you sort of spoken to it a bit, Bola, when you said fidelity to values is important going forward. But maybe could I ask the same question, but particularly aimed at church leaders, those who are leading these institutions that are feeling like they're declining in trust, church leaders who've also been through a pandemic, doing such a great job at the front line, but many of whom that I work with, running a national organization with lots of different church leaders, the word I'm hearing so much is burnout. You know, there is an erosion for them around their emotional energy, a raising in cynicism, and a feeling that they're being ineffective in their place. So I wonder if you could speak a little bit to that and how we can help our church leaders around raising their sense of their values and the trust in that they need to have in their communities to do this important work around health inequalities.
Thank you, Gillian. I think there are two dimensions to that question. So the first, in terms of the erosion of trust in institutions, that is exactly my point, that it's really important to recognize that what people value is relationships, not institutions. And the more the church conducts itself, not just the leadership, but actually the church, in its broadest sense, conducts itself in a way that elevates relationship above institution, the deeper the trust. When I was asked during the course of the pandemic, and Russell, you very kindly referred back to the work we did with the minister, I was asked many times by ministerial colleagues about this question of trust and why is it that people have such deep trust? And I said, because the church is there from cradle to grave. The church is there not because it's paid to do a job, but because it cares about you and it has a relationship with you. When your kids are born, guess who turns up? It's the pastor. When it all goes dreadfully wrong, who do you call? And therefore, the trust has been built on that basis. And my view would be, the more we go back to relationship rather than institution, the deeper trust will be. And then the second part of your question, in terms of how we support church leaders from a burnout perspective, connection with purpose and others. I think it's really important to understand that this is not a call to soldier on alone. And I do think that the more spaces are opened up for connection with the principal purpose, what was it that brought you into this ministry in the first place? And then who are the other people that you're traveling with? And how might you support one another? I think connection with purpose and others is a really important sustaining mechanism against burnout.
That's brilliant. Without showing a bias in this call to people from Hampshire, I'm going to come to Chris Bradish, who's asking a question about, I'm going to let Chris ask his own question from Andover in Hampshire. Chris, come in.
Thank you so much, Russell, and also Bola, for your presentation. It was really inspiring. I lead a church here and a staff team, and we have been co-located with our local PCN for the last couple of years. So we actually share a physical office together, and we've done loads of collaborations, and it's a really interesting kind of model that we're pursuing and finding some encouragement in. I would love to know, how do we as the church retain our distinctiveness, especially around kind of faith narratives within this conversation? Because as we've kind of crossed borders into NHS conversations about A&E waiting lists and all sorts of things, which has been really interesting, we've noticed that they've been doing a lot of leading through us. And it would be good to just hear, how do you think the church can retain its distinctiveness and its unique contribution to these partnerships within a kind of a faith landscape, keeping the faith conversation in the agenda somewhere?
Thank you, Chris. And I think your question maybe goes back to the heart of what I was saying right at the beginning about values and alignment and so on. I think retaining distinctiveness is just maintaining that clarity of purpose, mission, and values. And there will be points of intersection, and there will be points where it might be more difficult. and being clear about that. You know, somebody once used the analogy about it is possible to collaborate as and this is going to come across wrong because I'm trying to paraphrase somebody else's saying. They were essentially saying that collaboration doesn't necessarily mean you have to become an omelette, that you can collaborate by being a fried egg, whereby you retain your nucleus and you retain the essence of who you are and what you stand for, and collaborate at the edges where there are opportunities to collaborate. And I find that metaphor very helpful in a sort of visual way of thinking about the question that you've just posed. And I think constantly asking that question is really important. Going back to what I said about trust, you know, because for me, it's really important that you know, change travels at the speed of trust. And that's not original. I'm not sure who said it, but I find it a really powerful saying. And it's important in the midst of all the great work that can be done, that there is that holding fast to why is it that the community and people trust church, not church the institution, church the relationships is what I mean. And making sure that we are constantly asking ourselves the question, as we collaborate and partner, is the nucleus holding fast?
Very, very helpful. Thank you, Bola. I like the omelette and the fried egg. I like, as a preacher, I live by these kind of metaphors and analogies. So I've heard the kind of salad and the stew one before around it all merging in or thing being distinct, but we've now got a new one for that. So that's great. My congregation, thank you for giving me a new metaphor. We're going to hand over to Dudley. Anna from Revival Fires Church, again, doing amazing work in this space. And Anna wanted to sort of help us start to think about how we can maybe make this more normal across the ministry of the church, across the country, and how do we begin to start to communicate what's going on in small pockets and having a huge impact? How do we make this a sort of standard ministry for churches across the country? Anna, have you got any thoughts on that for us?
Yeah, yes, I do. Thanks for having me, and thank you, Professor Bola, for speaking and sharing. When we had Dr. Ross start the Listening and Guidance project here in Dudley as part of the social prescribing framework, so many others, many of you who've messaged me already in my NHS work have said, how do we roll this out at a wider level? And so Listening and Guidance is wonderfully established within Dudley, but I know that it's not across every single PCN, or there's not a chaplain attached to every general GP in general practice. And so just looking at what you said, and when you said, Bola, and your ask is, how can we support the ambitions of tackling health inequalities? And how do we learn from one another? How can we establish what God has placed within churches' mandate? And how can that then look at together working? I know that lots of people use a phrase, joined up working, but how can we together improve the quality of life of the population of England and beyond? How do we do that together, learning and pioneering and encouraging one another?
Go, Bola.
Thank you, Anna. I think it's a really great question. I think it's forums like this, sharing and learning. I think, you know, just intentionally opening up this space, you know, going forward, I think is very important as a mechanism for sharing and learning. You know, there are various other tools. Maybe there is opportunity for church works to consider building a community of support and learning virtually, where people can contribute case studies. Look, this is what we're doing over here. This is what is helping us. This is what is getting in the way. Could be something very useful, because then it means we don't reinvent the wheel. It means that we know who is already working in this area that we can reach out to for support. So, you know, my last slide was actually what we call the NHS Futures Collaborative Platform, and that is a community of support and learning and sharing that we've built, which is where people contribute their case studies, they share issues that they're dealing with, and they have the opportunity for somebody to say, oh yes, we were faced with that, and this is what seemed to help. So I think opening up these sorts of spaces on an ongoing basis, both physically and virtually, and then creating an online community of connection and support would be worth thinking about.
That is fantastic. I would like to a couple of things coming up on the chat, but particularly about ICBs, Integrated Care Boards, and we've got Ellen, who's just been appointed as Vice Chair of Cheshire and Merseyside Health and Care Partnership. So big congratulations to Ellen. We're really glad you're here, and also Steve, you're here. Steve Botham from Gather, and I know you've been working with some ICBs. I think it'd be really helpful. Personally, not everyone on the call might understand what an ICB is, so give us a little insight into what an ICB is. But it'd be great to get a bit of learning from you. How can churches be well kind of patched into their local ICB, and what are some of the things you're finding in these early days of working with these bodies?
Yeah, they've been in place more or less 12 months, and obviously there was some degree of preparation. One of the things that really struck me, I've been working very closely with the Birmingham and Solihull, which is the biggest one in the country. I was with their exec team on Monday, and part of what they've done is create a manifesto for Birmingham and Solihull, and the whole issue of tackling health inequalities and working with communities is really, really high up their agenda. At the same time, they're also trying to struggle with setting the integrated care boards up and 101 issues that have been put forward that are hitting the newspapers every day. The idea is that this is the pulling together of all health in the area, and it's not just looking at the provision of health, it's looking at doing more work in terms of prevention. It's probably a change in terms of health which will last at least 10 or 15 years. I would hope so, although there is some thought that we'll go back to some more regionalised structures if there's a Labour government. So the integrated care boards have got a lot of responsibility to look at health, and they've got a lot of muscle to try and drive things forward. With the Black Country, which Anna's part of, the Integrated Care Board has set up some open sessions. They've invited about 120, 130 people to these sessions to look at community engagement, what the priorities are, what the issues are. And the guy who heads up the communities work has been meeting with some of the church leaders across the Black Country and going, how do we work more closely together? And I think the key thing for me, my key observation, but I'd be really interested to know what Bola's feelings are on this, is that what they're looking for is who's going to come forward with some ideas. Because it's sort of like on this issue of community and community support and prevention and all these issues, there's sort of a dearth of ideas. There's a sense that we need to be doing something, but it's sort of like what? So my colleague Mark, who's on the call as well, has put some proposals forward in Cambridge. They're looking at and moving forward. But I think that whole, how do we work together in a collaborative way across churches, across different organisations to put some strong, effective community-based proposals is something that we need to build some traction on. But I'd be interested to hear what Bola's experience has been on the past 12 months in terms of what's changing and what she sees as good practice.
Bola, before you do that, I have long learned that one of the key things about being a chair, if you want to remain popular, is finishing on time. So we will finish on time. So I'm going to give Bola sort of 30 seconds to try and respond to how might we kind of engage well with ICBs, because then I'd like to round. I know that Desi from the National Academy of Social Prescribers, I'd really like to hear a bit about some of the resources they have available to us. So I'm going to give you guys a kind of a minute to do that before I wrap up at the end. But Bola, just give us that first thought on engaging with ICBs. Anything you feel is Steve right? Is now the time for the churches to come forward with ideas for them?
Steve is absolutely right. I often say we're not short of policies. We are awash with policies. We're not short of strategies. We're drowning in them. For me, it's about policy into practice. It's about analysis into action and turning the rhetoric into reality in people's lives. That's what the church does really well. And I think gathering people together and saying, what are the issues and what might help? And coming forward, as you said, Steve, with some which is why I deliberately in my presentation called out specific examples of practical, tangible action. That's what ICBs are looking for rather than help us shape yet another strategy or, that kind of thing. So I think the more the church can come forward with, here are a list of things that we think will work, and this is how we might be able to help. That solution space, I think, is precisely where we need to be located, and not wedded to models is the other thing. Just go where the energy is, and don't get stuck with models, because that can be excluding as well. Just understand however you're doing it, as long as it's answering the exam question, it's fine. It does not need to have a particular label or fit into a particular model. It just needs to answer the exam question about what matters in people's lives, would be the other thing to say.
Brilliant. Thank you, Bola. Thank you, Steve. As the chat says, Steve is always right. So, Steve, you've got a vote of confidence from the room. Desi, would you just give us 1 minute? What can we get from the National Academy of Social Prescribers that will help us to take this message to the churches and beyond?
Thank you very much, Russell. And yes, I'll be very, very happy to invite people to go to our website as a start. There's a lot of resource generally on social prescribing, case studies and examples about how different organizations across different sectors are trying to and successfully to connect to social prescribing to their health partners in region, in locality, and support people and their health needs. Specifically, when we talk about churches and place of worship more widely, we started looking at that very important role that those places and faith communities have in meeting those needs. And so, like many of you know, we had a webinar in December last year, together with ChurchWorks, specifically looking at the role of churches and the possibility for them to deliver social prescribing. And there are such a good examples, some really, really good case studies that were already presented then. But obviously afterwards, we were also keen to give a voice and opportunity to other faith groups and place of worship to equally open up to their communities the work and the opportunities that they do. Hence, on the 12th of September, we have another session, another webinar, which I put the links in chat, so you're very welcome to come and join us to see what others are doing, because I completely agree. There isn't a model, there isn't a strict way in which we can do that. It all depends on where we are, what are our needs, and what the partners available are. But at the National Academy of Social Prescribing, we're trying with our regional leads, and I know one of them is here, and they also work with people they know specifically in those localities to support organizations across sectors, including churches, especially because of their traditional and extremely significant role in supporting individuals and communities' well-being going forward, to optimize and maximize this. So more case studies and more information shared, the better. And I'm sure that we'll find more opportunities to do that going forward.
Desi, thank you. That was superb. It sounds to me, and I'm sure we will take this conversation offline, but Dr. Bola, it does seem to me that we could, there might be some, thinking about what next steps, there might be some opportunity for a kind of NHS ChurchWorks Core 20+5 kind of conference or some training to try and take that to the thousands of churches that are connecting with ChurchWorks and try and make them part of that strategy going forward. We will take that conversation offline. We are really grateful for all the thoughts, and we know people are on this call because you're continually sending us your ideas and sharing what's going on locally. Thank you so much for that. Please don't stop doing that. The ChurchWorks team want to try and help the church to develop a really coherent but powerful strategy around this. It just falls to me to say, firstly, thank you to everyone. Bola, thank you for being with us. Thank you for our speakers, to Ross, to Faith, and to Mike, to all of you for giving up 90 minutes to be on this call. Not only thank you for being on this call for 90 minutes, but thank you that being on this call is precisely because you're devoting so much of your life to doing this on a daily, weekly, monthly, yearly basis. And it feels like we're at the beginning of a really exciting moment for the church and for the country. If it's all right with you, I would love to close in prayer. Being an Anglican priest, I'm on commission, and I need every penny I can get, and I get more if I pray more. So if that's okay with you, that's a joke, by the way. If anyone starts writing letters into the Archbishop, I would love to be able to pray for everyone on this call, because what you're doing is so important at this time. Shall we pray? Father, we thank you for this conversation. We thank you for the work that churches are doing across our nation to bring good news in so many forms to people who need it in so many ways. We thank you for Bola and what she is doing to lead this work in the NHS. We thank you for Ross and for Faith and for Mike and for everyone else on this call for what they are doing on a daily basis to try and change the lives of so many people through the ministry of the local church, working in health and well-being. And Father, we pray that you would bless this conversation, that it would not stop here, and that it would become something of a movement across our country of churches seeing people's lives change by the good news that only the church can bring through Jesus in so many practical ways. So please, Lord, bless us, inspire us, help us to continue to make a difference and do something with us that affects the lives of our nation. We ask it in the name of Jesus. Amen. Thank you so much for being with us. Thank you again, Bola. Thank you, Ross, Faith, and Mike. Thank you, the rest of you. Have a great day. I hope you get a summer holiday sometime soon, and look forward to seeing you.